Ladies and gentlemen, it's a real pleasure to be here, and I would like to continue the interactive part we have had just recently, and I start my presentation, these are my disclosures, with two questions, and the first questions are open, so just feel free to answer. There's not a real wrong or right. And my first question is, what is, due to your opinion, the itch-causing substance in primary biliary cholangitis? Is it maybe histamine? Do you believe it's the bile salts? Do you rather think it's endogenous opioids, progesterone metabolites, maybe lysophosphatidic acid? Or do you believe we do not yet know the factor which is causing itching in these patients? So please vote now. We wait a few further seconds, and then we go to the second question, and you will get the answers in a minute. No? Very good. So the majority of you believes we don't know that yet, and maybe you are not so wrong, but I will tell you that we know already quite something on that, and I will show you what has been published on that. And then we have the second question. So what do you believe is the most effective drug to treat pruritus in women with, or male patients with primary biliary cholangitis? Do you think it's the antihistamines? Do you rather think cholestyramine is more effective, or maybe rifampicin? We already had some discussion on that. Fibrates have been discussed, sertraline, or maybe gabapentin. So there is no right or wrong. It's maybe your personal experience, what you would give to these patients. Okay, rifampicin, I'm very happy with that. Sorry for that. And 80%, this is indeed also due to my personal experience, the most effective drug. Okay, you are all aware about this bothering sensation of itch, latest when you get in contact with certain animals or plants. For example, this mosquito or this stinging nettle. You get a reddish swelling, and this is itchy for a few hours or maybe even days, and you may scratch that itch. Okay, and you're all smart, and you know that the signaling molecule is mainly due to histamine. But you are also aware that chronic pruritus can be way more bothersome for the affected patients, and just imagine how horrible must be the itching of these two gentlemen suffering for many years, all over the body, 24 hours per day, which dramatically reduces the quality of life. And exactly in the itch of these two gentlemen I'm interested in. What is the equivalent of histamine in these two gentlemen? What is the X factor, or rather call it the itch factor in these gentlemen? Now, I have to give you a little explanation on what we know about on itch perception. 20 years ago, people believed itching is the little brother of pain, and a little activation of certain sensory neurons would result in itch perception, whereas a stronger stimulus would result in pain. And only in the end of the second millennium, neurophysiologists identified that there are certain specialized neurons which only responded to histamine, but not to certain pain stimuli, such as mechanical pain. And in recent years, we know that there are other specialized neurons who do not respond to histamine, but to non-histaminergic itch stimuli, here, for example, indicated in red, and they respond to certain drugs, such as chloroquine, but also proteases or cytokines. Now, when these neurons are activated, we get an action potential, which is here at the dorsal root ganglia, and then via the spinal cord, some interneurons transmit the signal to the brain, and certain areas in the brain are activated. Now, although I told you that itch and pain may be transmitted via different neurons, they are very closely intertwined. Now, just a scheme here. You may imagine this is an itch neuron, a specialized neuron for itch. In gray and in black, it's the pain stimulus, which is transmitted. And we have on the left the skin, we have the dorsal root ganglia here, then the spinal cord with the interneurons, and here the brain. Now, what do you do when you feel an itch? You scratch. And why do you scratch? Because you want to activate these pain neurons, because the itch neurons are under an inhibitory control of the pain neurons. And one proof that this is the case is the application of opioids or anesthetics closely to the central nervous system. If you don't feel in pain, a certain percentage of patients will experience an itch. Now, this is very interesting. So mu-opioids, for example, do that, but also other drugs. And there is another class of opioids, namely the kappa opioids. They inhibit pain sensation, but keep on this inhibitory control. And I will come back to that in a minute. Now, of course, you are very well aware that there are many internal disorders which are associated with pruritus, chronic renal failure, hematological disorders, and of course, several cholestatic liver diseases, and they are shown here in regard to the site of injury in the biliary tree. It may be a pure hepatocyte secretory failure, as seen for intrahepatic cholestasis of pregnancy, or drugs, or hepatitis C. It may be primary biliary cholangitis, here the destruction of the smallest bile ducts leading to secondary secretory failure, or it may be obstructive cholestasis, for example, in PSC tumors and other diseases. Now, today we focus on primary biliary cholangitis and what is typical for these patients. For immune-mediated liver diseases, patients typically report that the pruritus is felt most intense on the limbs and mainly on the palms and the soles. This is very characteristic for PBC and PSC patients, which is hardly seen in other internal disorders. We see a circadianism, which is not very specific for cholestasis. This is rather a common event. And interestingly, women report that pruritus worsens premenstrually during hormone replacement and late at pregnancy. So whenever a woman reports about pruritus late in pregnancy, do not always judge this as intrahepatic cholestasis of pregnancy. This needs or requires a proper follow-up. Now, several hypotheses have been made what is the cause of pruritus. And of course, the first one was bile salts. And of course, they are increased during cholestasis, but they hardly induce pruritus. If you inject bile salts into the skin, you can hardly induce pruritus. You need suprapathophysiciological high concentrations to induce pruritus, which you never observe in a cholestatic patient. Anion exchange resins, which bind bile salts, but also a lot of other substances in the gut lumen, improve pruritus. And of course, we have heard that obeticholic acid as a bile salt can somehow induce pruritus. Also, we do not yet know how that works. However, nobody so far observed any correlation with the itch intensity reported by a patient with the concentration of bile salts in the bloodstream or in urine or even on a skin level analysis. And the causal relation is somehow difficult because you cannot directly activate neurons by bile salts. Now, a more recent hypothesis by Anthony Jones and Nora Bergaza was that endogenous opioids would do the job. And I indeed told you they can induce pruritus, particularly if you apply them closely to the central nervous system. However, if you look at the patients, the levels are only increased in a very few patients. And of course, in the 90s, people argued that mu-opioid antagonists, naloxone, naltrexone, improve pruritus. So they said, yes, it's the endogenous opioids. But also here, nobody observed the correlation with the itch intensity. And interestingly, we rather observe an inverse correlation, namely, if the liver disease progresses, the only thing which improves may be pruritus, but the opioid levels will rise in these patients. Now, maybe modulation by bile salt and opioids may be a role, but no direct causal activation of neurons. Now, more recent hypotheses were progesterone metabolites, and indeed they are increased in these women with intrahepatic cholestasis of pregnancy. When you inject them intradermally into mice, you can even induce a scratching. And there is a bile acid receptor, TGR5, it's a G protein coupled receptor, described for bile salts. I personally believe it's not a receptor for bile salts, it's rather a receptor for other substances such as progesterone metabolites can be activated here in the dorsal root ganglion. Also here, we do not know any correlation with the itch intensity, and it seems to be rather a mediator maybe in these pregnant women. So there must be something else, and I will come back to that in a minute during my talk and present those data later. First, I would like to let you know what we know from a clinical perspective on the itch-causing molecules. And we know that they accumulate in the circulation, and you have seen the data on the albumin dialysis, for example, the molecular adsorbents recirculating system, MARS, that improves itch sensation in patients with very severe refractory pruritus, shown by several case series here. They are not randomized, not controlled. That would be very, very difficult. And we also face the problem of psychological effects. We have heard the presentation about hypnosis, so it's a psychological problem, but we believe that there is a certain effect, as the effect is quite strong. And if you treat those patients twice after pruritus has come back, this can be an effective treatment again. So I will come back to that later for the identification of pruritogens in a minute. We also know that these substances are secreted into bile and undergo an enterohepatic cycling. And also here from experimental procedures, patients who are unresponsive to any treatment and are eager to get any treatment can be treated with a nasobiliary drainage. You put in the drain here and you drain out the bile of the body and thereby totally interrupt the enterohepatic cycle. And this leads to a really very strong improvement. Within 24 hours, the patients wake up the next morning and smile for the first time. That was the first night I could sleep again. So this is very effective. However, when the drainage has to be removed, pruritus comes back in all of these patients within weeks to latest months. Now, a medicinal way to interrupt the enterohepatic cycle is cholestyramine. And some case series have been published in the 60s and 80s, and that's why cholestyramine was put in as first-line treatment in the current guidelines. And these are the European guidelines. They say you should treat those patients first with 4 to 16 grams per day. And be aware, particularly bile salts, ursodeoxycholic acid, but also a lot of other drugs are bound by cholestyramine. So please, if you use cholestyramine, do that 4 hours separate to any other drug intake. Now, there has been a well-defined placebo-controlled randomized trial with colesevelam. This is a bile acid resin which binds bile salts much better than cholestyramine. And indeed, the bile salt levels dropped by 50% in those patients on colesevelam, but the effect on pruritus was the very same as in the placebo group. So this certainly questions the role of cholestyramine. We would have to perform a placebo-controlled trial to see whether cholestyramine binds the itch-causing substances in bile better than colesevelam. Of course, we do not know that. Now, a third thing we know from clinical observation is that these pruritogens are metabolized somehow in the liver and in the gut lumen. And we know that from the antibiotic drug rifampicin, which is not only an antibiotic drug, it also binds to a transcription factor called pregnan X receptor. And you know that you get a lot of interaction when you treat patients with rifampicin because cytochromes are upregulated, a lot of transporters. So metabolism is altered, but also the secretory function is improved. And 4 placebo-controlled trials have been performed showing that rifampicin is effective compared to placebo and safe if you do that on a short-term basis. And the standard median difference here in the meta-analysis is -1.6. So Rifampicin is the second-line treatment in the current guidelines, with dosages of 300 to 600 milligrams per day. But be aware, hepatitis, hepatotoxicity may occur in 5 to 10% of the patients, so you should control for transaminases. But if it's tolerated, it can also be very effective on a long-term treatment. Now, finally, we know that the endogenous opioidergic and serotoninergic system is modulated. And I told you mu-opioid antagonists such as naloxone or naltrexone have been reported to be effective. The effect is milder. You may appreciate that here in the meta-analysis, the standard mean difference is only minus 0.6. So it depends, and quite some side effects may also occur. That's why naltrexone is only recommended as third-line treatment with a dosage of 25 to 50 milligram. And some patients may even experience some withdrawal-like symptoms, and if you want to avoid that, start with a very low dose, 12.5 milligram, or even a naloxone infusion that can overcome these problems. Now, finally, there's one trial using sertraline from Mayo in 2007, and you may appreciate that some patients with sertraline had quite some effect, whereas the placebo group did not, but it was not a properly performed trial because everybody received in first instance sertraline, and then later on the randomization to placebo took place, so this is a bit shaky, but it can be used as fourth-line treatment at a dosage of 75 to 100 milligram. Now, using this regimen, you can treat 50 to 60% of your patients quite well if you do that in a proper way. However, there is a remaining percentage which do not adequately respond to these drugs. And then you have experimental options, for example, ondansetron, some conflictory data on that, nasopillar drainage, albumin dialysis, I've told you about that. Even liver transplantation has been performed, as liver transplantation, in contrast to fatigue, will improve pruritus, at least in the majority of these patients. Now, what do we do with those patients who do not adequately respond? Is there anything new? Yes, there is. There are fibrates. You heard already something about that during the previous talks. Nalfurafine, a kappa opioid agonist, gabapentin, pregabalin, and IBAT inhibitors. I will go through those 4 drugs. So fibrates are PPAR agonists. They exert anti-cholestatic effects, and they have been reported to be effective also on itch perception. There is no, so far, placebo-controlled trial. Only retrospective analysis have been published. And this year on EASL, Paris showed this poster where you may appreciate that on a visual analog scale, itch perception went down. Actually, it's a numeric rating scale, not a visual analog scale. And there's quite a high number of dropouts which are not followed up anymore. But he claims if fibrates are stopped, pruritus came back, at least in certain parts of these patients. So fibrates are, of course, interesting and worth a try. Now, nalfurafine is a kappa opioid receptor which is licensed for uremic pruritus in Japan in 2009. And this was the study which led to the license for this drug. And you may appreciate that the effect here at 2 dosages, 5 and 10 microgram per day, was weak, 9 to 10 millimeters on a visual analog scale. But that was enough for the Japanese authorities. And they further published an open label arm where the effect is somewhat stronger without a placebo control. Now, interestingly, nalfurafine is licensed to treat cholestatic pruritus in 2015 in Japan. So if you want to get a drug licensed, start maybe in Japan, it seems to be somewhat easier because no data has been published on the clinical data on that drug. But it's interestingly. Now, gabapentin and pregabalin are drugs which are established for neuropathic pain. And chronic kidney disease-associated pruritus improves quite well if you use these drugs. Now, there is one randomized controlled trial with gabapentin published in 2006 by Nora Begaza, 7 versus 6 patients, quite a low number, and they were treated for only 2 weeks with negative result. That's why this disappeared. However, a proper effect is not seen within 2 weeks. It just takes longer, 6 to 8 weeks. And we retrospectively analyzed these data and observed that the visual analog scale dropped from 8.4 to 2.6, so that's quite a strong effect if you just treat those patients long enough. So that may be an interesting drug as well to use if you are not able to include patients in current clinical trials, for example, the IBAT trials, the ileal bile acid transporter, which is the transporter reuptaking bile salts from the gut lumen to the bloodstream in the ileum. And 3 phase 2 trials are currently taking place. And so just to illustrate that once more, the ASBT is here in the ileum, responsible for the reuptake of bile acids. And when you block that, then bile acids are not taken up. And if bile acids would do the trick, or maybe other substances are also uptaken via the IBAT transporter, we do not know that. But then you would expect that pruritus is improved, and the first data has been shown at EASL this year, maraliximab or lupiximab or LUM001, different names for the same drug. Unfortunately, the 10 and 20 milligram dose was not better than the placebo group. The placebo effect is quite strong here, but still it's questionable how this can be explained. Anyway, we wait for the other compounds to be published. The other drugs seem to be somewhat more effective, and we have to wait for ASLD or EASL next year. Now, the question is, what is now the real pruritogen in these patients? And of course, we questioned ourselves how to solve this problem. And when we come back to the accumulating factor in these patients in serum, we said, okay, there is somehow a factor in the circulation, let's call it factor X, which accumulates, which somehow can activate these itch neurons or specialized itch neurons. And we therefore screened our samples for neuronal activation. And interestingly, when we did that in a human neuroblastoma cell line, we observed a transient rise in cytosolic free calcium concentrations. And this rise was stronger in women with primary biliary cholangitis with pruritus compared to those women without pruritus and healthy controls. So this made us very curious about the neuronal activator. And we really performed a battery of physical and chemical experiments. I don't want to go into detail, but in the end, we could identify the factor as a little phospholipid called lysophosphatidic acid. And now the question was, could we trust these results? Because we have a neuronal activation, but does that cause itching? And therefore, we first challenged mice. And we injected this compound intradermally into mice, and you may appreciate that the scratching activity in these mice here, indicated by the red bars, is stronger compared to the vehicle control. And you may argue mice are not men, and therefore, of course, we applied that to human beings very recently. And you may appreciate that it's a mild itch perception, but these are healthy volunteers. We're currently performing these experiments in cholestatic patients. There is a mild itch induction in these humans. Now the question is, where does LPA is derived from? And extracellular LPA is solely synthesized by one enzyme called autotaxin. And as LPA was increased in our patients, we were wondering whether autotaxin is also increased. And indeed, this was the case when we looked at patients with pruritus, irrespective of the underlying disorder, whether this was PBC, PSC, or HCV, or a tumor. Only those with the itch perception had the increased values, and the amount of protein was increased compared to those patients without pruritus and healthy controls. And even stronger, we could show that there is also mild, but there was, for the first time, a correlation with the itch intensity, which may also be due to this with very severe pruritus. Now, coming back to the first experiments, the albumin dialysis, when we looked at our molecule, the autotaxin activity, we observed that there was quite a nice correlation between itch intensity and autotaxin activity in these patients, but this was also the case for nasobiliary drainage and rifampicin treatment. Now, did we solve the mystery of cholestatic pruritus? Well, we could show that factor X may be lysophosphatidic acid, which is synthesized by autotaxin, and autotaxin inhibitors and LPA receptor blockers have to prove in humans whether this is indeed true, whether LPA can induce pruritus, and whether these drugs may inhibit itch signaling. But is this now the whole story? Did we solve the whole problem? Most likely not, as autotaxin is also increased, for example, in regular pregnancy. There must be another substance, which is called factor Y here. There must be an additional factor to cause cholestatic pruritus, but we are far beyond only scratching the surface. We digged so far and opened new avenues for therapies. Now, finally, I would finish my presentation with a little case report. And to get you all awake again, a patient with primary biliary cholangitis presented at our ward with 38 years, and she was treated with urso only 1 gram per day, no other oral drugs. Now, this woman came to our ward, and she reported that pruritus, she suffers now from pruritus, and she has read that this may be due to the PBC. And she said, well, the intensity is as strong that she really wants something to be done. 8 out of 10 on a numeric rating scale. Now, asking where is the pruritus located, she says, well, the extremities and the chest mainly was the location. And then, of course, we ask, well, did you do something special? Did you change something special? And she said, well, no, actually, the only thing we could investigate was that she was in Thailand 3 months ago. And since then, she also has some night sweats, at least, she reported. So transaminases and cholestasis parameters were largely unchanged, so it was not a worsening of the PBC. And the question is, if this patient sits now in front of you, what would you do next? And you are allowed to vote again. So would you prescribe her a topical treatment and say, we try that first? Or would you say, well, start cholestyramine, let's say 4 grams before and after breakfast, and take urso only in the evening? Would you consult a dermatologist and say, well, could you perform a skin biopsy? Would you perform a physical examination? Or would you maybe check for HCV or HIV infection? As, well, she was in Thailand, she's a single woman, and so, well, we so you are allowed to vote. So very good, very good. The physical examination is always good to perform. I always recommend that to my students. Dermatologists, of course, if you are uncertain, may also be good. HCV and HIV infection. We checked for that, I have to admit. But when we performed a physical examination, a proper physical examination, we observed that there were increased axillary lymph nodes on the right axilla up to 4 centimeters. And so one of those was taken out, and Sternberg rate large cells have been reported by the pathologist. So she had a nodular sclerosing Hodgkin lymphoma, and it should always tell you that you should be aware that also another disease may cause pruritus in these patients, and not just to discard that as cholestatic pruritus. And with that, I would like to finish my presentation. So I hope I could show you that the causal substances are not histamine, likely not bile salts and opioids in these disorders. Lysophosphatidic acid, which is synthesized by autotaxin, is increased in these patients and induces scratch responses in mice and pruritus in human beings. The treatment guidelines, the current treatment guidelines recommended are a step-by-step approach, starting with cholestyramine, rifampicin, naltrexone, and sertraline. Cholestyramine is the only licensed drug to treat cholestatic pruritus, by the way. All the other drugs are off-label use. Experimental approaches should include fibrates, gabapentin, or invasive procedures such as albumin dialysis or nasobiliary drainage, and maybe in the future, autotaxin inhibitors or LPA receptor blockers may represent a potential antipruritic treatment strategy. And with that, I would like to thank you for your attention.
So thank you, Andreas, for this outstanding talk, really. I'm sure many questions. First questions, are there any ongoing clinical trials with autotaxin inhibitors or LPA receptor blockers?
Well, there are only a very few trials going on, but not with pruritus. They are focusing on neuropathic pain, as LPA seems also to be involved in neuropathic pain. And so far, we have to wait until we are able to treat patients with pruritus with these drugs. It's interesting, as neuropathic pain is also associated with pruritus in 1/3 of the patients. So it could very well be that these drugs may also be effective, but we still have to wait for that. Autotaxin inhibitors, you block the whole LPA pathway. I don't think that this is very suitable, because you block 6 different LPA receptors. With that, I doubt whether this is suitable. So maybe in the future.
Christophe?
Andreas, excellent as usual. Two short questions. What is your own experience about gabapentin in cholestatic pruritus? And second, you didn't talk about TGR5 in neuronal spine cord. So
yeah, very short
comment.
I have quite a good experience with gabapentin or pregabalin. You have to be aware that it's secreted via the urine. So once you have a renal failure or a reduction in the GFR, you have to reduce the dosage. But you have to wait long enough, 6 to 8 weeks, and then often I add these drugs to other drug regimen. So if you are not happy with one single drug, you may add that drug, and that helps for those patients. The second question is TGR5. I think I have brought here one slide. The TGR5 is now this so-called bile acid receptor, a G protein coupled receptor on the membrane of cells. And it was, interestingly enough, discovered on dorsal root ganglia, so where all the sensory input is located. Now, Mother Nature doesn't put a receptor there if this is just for pleasure. There must be a role, but you need supraphysiological high concentrations to activate TGR5. So deoxycholic acid, well, a significant effect was only there with 100 micromolars, and also the release of each signaling molecule, the gastrin-releasing peptide, required 100 micromolars. You never reach 100 micromolars, and on top of that, deoxycholic acid is not a predominantly present bile salt. So it's a receptor for something else, and I personally believe that it's rather the progesterone metabolites.
Oui.
Je peux te poser en français, puisque tu parles très bien le français.
Bien sûr.
Tu as dit que Prurit, ça ne voulait pas dire toujours cholestase. Et effectivement, on a souvent des problèmes. Est-ce que tu commentes sur la valeur diagnostique de la mesure de l'autotaxine? Est-ce que c'est vraiment spécifique? Est-ce que c'est...
Tu es d'accord si
tu parles en anglais.
En anglais. So the diagnostic value of autotaxin is only there when you have very high levels. So at the low range, that is with a lot of other tests, when you have low levels, you cannot say anything. But if you are uncertain and if you have the typical older patient with chronic pruritus, where the dermatologist told you, this is not the skin, it's something else, and you're the internal doctor, do something for him, then you can check, because those patients have a chronic renal failure, they have elevated liver diseases, liver enzymes for whatever reason, they have a thyroid disorder, and then you question what may be the cause, and this may help you to distinguish whether this could be the liver. On the other hand, you could also follow the current guidelines for chronic pruritus and do a stepwise approach, and they always start then as a medicinal treatment with gabapentin and pregabalin. But only the high levels are specific.
Okay, last question.
Congratulations. 20 years ago, about 20 years ago, 2 short series were published about the usefulness or less usefulness of grapefruit juice in Pruritus of Cholestasis. Have you the opportunity to test it seriously?
Well, you know, I always appreciate these studies, but be aware, look at the maralixibat trial. The placebo effect can be very strong. Huh? No, it's not. It has a lot of interaction, but if we look at the beneficial effect of rifamycin, which is rather an inducer of cytochromes, and grapefruit juice is rather an inhibitor of the cytochrome P450 pathway, of course we do not know. It's a black box. We do not know what happens there, but I would rather think that this is from the known knowledge on rifamycin, this should rather be not effective, and you would perform a placebo-controlled trial. By the way, if you have a patient on your ward and you want to treat him initially, yeah, and you want to have a strong placebo effect, you just give him an infusion. And if you want to have a stronger effect, you inject the vitamin B in your infusion, so it has a color. Reddish color, vitamin B12 is very good. And if you don't have the strongest effect on a psychological way, you put aluminum foil around your infusion, then you have the strongest effect.
Okay, very, very last question.
As you mentioned, rifampicin is an inducer of CYP3A4. Have you tried other inducer of 3A4 to treat pruritus?
Phenobarbital, for example, has been used also as an inducer of CYPs in the liver. However, the effect was less pronounced compared to rifamycin.
Okay, so thank you again, Andreas. It's time for break. So we have 10 to 15 minutes.